Today I'm going to be talking about the Klein-Bell scale for ADLs and IADLs. A little bit of the description is a Klein-Bell ADL and IADL scale measures a person's independence when it comes to performing basic self-care activities of daily living. This is measured if the individual can perform daily tasks independently. The population that the assessment assists is the primarily for people of cognitive and physical impairments like stroke and spinal cord, geriatric clients, and it also has a component that is linked to the ICF. And the age range is any age can do this assessment. So when it comes to the Klein-Bell ADL, it is an observational standardized assessment, and the categories include about 170 different types of behavior and within 6 domains of mobility, dressing, eating, personal hygiene, toileting, and emergency communication. The location could be the client's home and outpatient rehab, but it's mainly universal. The length of the time, when I did the research, it did vary, but between 30 minutes up to 3 hours, because each item does have a 10-minute time limit. So this kind of just breaks down the domains and behaviors. So the domain of dressing has about 65 behaviors, elimination has 23, mobility has 30, and then hygiene has 31, emergency telephone has 6, and eating has 15. And breaking within each domain and behavior, it kind of addresses certain things. Like communication is producing conversation and communication devices. Mobility is like transferring, carrying, and moving moving objects with the lower half, fine hand use, carrying body parts, toileting and dressing, and just so on. So this table just breaks it down, and the longer the line is the more behaviors it has within that category. So this assessment is off of your performance and also an observational checklist. So the client will be observed by the client therapist to watch for any defects in their skills and performance. So this KB scale was developed in 1982 by Ruth Klein and Bernard Bell. So the purpose of them coming up with this assessment was other ADL tools were too general and they didn't capture small components. So Ruth and Bernard designed this scale to provide a qualitative behavioral-based measure of independence in ADL's performance. When you perform the administration part of the assessment, you want to sterilize the environment if it's outpatient or within the client's home. And to perform the assessment, you want to read each behavior to the client and have them perform the behavior back to you. Scores are achieved or failed, and achieved is when the behavior is performed without verbal or physical assistance, and failed is when assistance is needed. And also, if the client uses any form of adaptive equipment to perform the behavior, if they don't need any assistance from people, then they still get full credit. Each behavior is assigned a weight of 1, 2, and 3 based on 4 different factors: the importance of health, the difficulty of non-disabled person, the time required to perform tasks, the burden of the caregiver. So based on that weight is how many points that each behavior is worth. So if it's weighted a 3, the max points you could get is 3. If it's weighted a 1, the max points you could get is a 1. The client's performance is rated and multiplied by the behavior's weight. The score range is 0 to 113. 113 is the max points you could get on this assessment. If the client refuses to do a behavior, they will receive a 0. If a behavior doesn't apply to the client, just put NA. There are some sex-linked behaviors, like putting on a bra, shaving face, and managing a menstruation cycle. The Klein-Bell ADL and ADL scale measures a person's independence when it comes to performing basic self-care activities of daily living. This is measured if the individual can perform daily tasks independently. This assessment has 6 domains, 40 subcategories, and about 170 behaviors. For the sake of the video, we're only going to be focusing on 6 subcategories.
Go.
Hi, I'm Brooke, and I'm just your occupational therapist, and I'm just going to be observing you doing some basic ADLs, which is activities of daily living. So we could just get started. The subcategory that we'll be observing is mobility through doors. This is under the domain of mobility. There are 5 different behaviors: open doorknob, open door towards self, open door away from self, closed door towards self, closed door away from self. You just operate the doorknob and then open door away from self and then close door away from self. Now we can go back in. Okay, now you can open door towards self and then close door towards self. Perfect. The next subcategory is obtaining clothing from closet. This is under the category of dressing, and there's 2 behaviors: grabs clothing hung in closet and place clothing within reach of dressing. Now you can grab clothing hung in closet and then place clothing within reach for dressing. Okay. Now you can reach shirt to top of head and then pull head through neck hole. Put right arm through the right armhole. Put right elbow into sleeve. Put left hand through left armhole. Put left elbow into sleeve. Pull shirt down over trunk. Perfect, good job. The next subcategory we're looking at is shoes, which is under dressing, and there are 6 behaviors with this subcategory. Okay, now you can place your right toe into right shoe. Place right heel into right shoe. Place left toe into left shoe. Place left heel into left shoe. Fasten right shoe. And then fasten left shoe. Good job. This is the last subcategory we're looking at. It's comb hair, which is under the domain of bathing and hygiene. There are 4 different behaviors that are observed.
Yeah.
Okay, now we're gonna do combing hair. So you could just grab comb and brush. Sorry, and brush. Okay, you want to comb top hair and then comb back hair, and then release comb and brush. Perfect. After the client finishes assessment, you want to collect the raw scores. For example, she got 65 out of 65 in dressing because there was 65 behaviors and she was able to complete them all. Nazareth does not have this assessment on campus, and the assessment is copyrighted, so I do not have access to a scoring sheet. The formula to find the independence of the client is you take the total score and divided by the possible score times 100. So there's 170 behaviors, and the client was able to perform all 170 divided by the total, which is 170 times 100. So therefore, her independence is 100%. There are some sex-linked behaviors, however, you just put NA and the client receives the points. Each behavior is assigned a weight, a 1, a 2, or a 3, based on 4 different factors: the importance of health, the difficulty it is for the non-disabled person, a time required to perform tasks, and the burden of the caregiver. These weights are seen right on the same line as the behavior right before the boxes. These weights will help the therapist to come up with intervention plans to help benefit the client to become more independent. The higher score means greater independence. This assessment is a criterion reference test. That means you use the client's score as a baseline and there's no norm sheet because you're comparing it to the performance. So the clinical utility is very highly sensitive in small changes, so this provides a clear picture of the level and type of assistance that the client may require. This also allows the OT to plan target interventions and communicate with the caregiver. The form could also be sent home with the caregiver and is also great to document for third party as well. This is because it's a quantitative scoring and behavior descriptor, so it also makes it very useful when it comes to documentation. So the original study iterative reliability is 0.92, which is high, and the test-retest reliability is 0.88 over 2 weeks. The validity correlation for the original study is negative 0.86 with assistant level, which is moderate. The other study I found, which is a high cervical spinal cord injury, the validity equals 0.63, which is low, and the 2-point discrimination test is 0.68, and a p less than 0.0, which is also low. The third study I found was ages 1.5 through 6 years old with CP. The iterative reliability is 0.99. The test-retest is 0.98, and the construct validity is p is less than 0.001, which is all strong. The last article I found was for children, and the inter-observer reliability is 0.99, which is high. The test-retest reliability is 0.98, which is also high. The validity is p equals 0.08, which is not statistically significant. Some factors that may create bias in the assessment is the setting. People may perform better if they're in a familiar setting versus like a hospital. The distractions of noise as well. It is a lot of listening and doing. So if it's a lot of noises, they may have a hard time paying attention. The time of day, a lot of people may feel fatigued or even just have a lot of pain at certain times of the day, which can cause them unable to do and behavior that they may be able to do. Also eating style. I have a photo up about one of the subcategories of eating solid foods, and a lot of it is using utensils. And if you're part of a culture that doesn't use utensils and you eat with your hands or even chopsticks, that might hinder the outcome of your independence level. So my questions are, the first one is, what domain do you think is the most important to benefit the client's independence? And if you could add a no domain, what domain would you add to enhance the KB-ADL scale? My second one is, what environmental factors might influence a client's performance on the KB scale, and how can those factors lead to an inaccurate level of independence? My third question is, in the KB-ADL assessment, the therapist reads each behavior and observes the client's performance of the behavior. Do you think that may hinder the client's true independence? These are my references. Thank you so much for watching.